Okay, we're going to proceed now with the next session. It's number 21, and it is called the Novel Diabetes Insights. So the first speaker is going to speak on novel insights on insulin resistance in pregnancy. It's Professor George Mastorakos. Professor Mastorakos is a professor of endocrinology at the National Kapostrarian University in Athens. He has served as the president of the Hellenic Endocrine Society and is actively involved in European endocrinology research networks. So, Professor Mastorakos, please.
Thank you so much for this kind introduction, and I have to thank Professor Inash Altut and the organizing committee for giving me the opportunity to be here in this wonderful country with exciting history and so kind people. So we decided with Professor Altut to go through this subject because I would like to share with you some data that we have been producing during the past 15 years, and eventually are going to give you some insights in this intriguing subject, which is gestational diabetes mellitus, which is not type 2 diabetes, which is not type 1 diabetes. It's maybe a mixture of both, or it's maybe something completely different. So this is my outline, and I'm going to go through with the subject starting in utero, starting in the uterus. So in this situation, which we call fetal maternal placental unit, we have three players. We have the fetus, and of course, a major part of the reaction taking place during pregnancy is the fetal genome. We have the mother, and here we have the mother with the maternal genome, and of course the maternal environment, which is represented both by the internal and external environment compared to the mother, because regarding the fetus, the mother represents the interface between the fetus and the external environment. And we have the placenta, where we have the famous hormone production, so much involved in gestational diabetes and in producing the so-called natural phenomenon of insulin resistance during normal pregnancy. I would like to attract, however, your attention on two things: that the placental blood flow, as well as the uterine artery flow, may play an important role regarding the expression of this interaction between the environment surrounding the mother and the fetus. Okay, let's go ahead. Here you can see in this relatively recent review a nice cartoon representing how maternal factors, let's say internal factors regarding the character of the mother, the way the mother behaves, but as well as her body physiology, together with lifestyle factors of the mother, can interfere and play contradictory roles regarding the development of hyperglycemia, which results to insulin resistance and associated to the subsequent hyperinsulinemia. From these factors that I'm not going to go over them, I'm interested to two of them: the obesity and the psychosocial stress. Obesity as represented by the adipose tissue of the mother, and you can see that the diabetes risk is highly increased when the metabolic capacity to face the developing hyperglycemia during pregnancy, as well as with the metabolic load, one is low and the other is high. And this could be just a cartoon in order to show you how I would like to develop this talk towards the idea that maternal adipose tissue influences the development of insulin resistance during pregnancy and is implicated in the development of the pathologic entity that we call gestational diabetes, and on the other hand, the maternal stress as it is perceived by the body of the mother when she responds either to internal stressful stimuli or to external stressful stimuli. And this is, I believe, an old cartoon, an old figure which represents very well what happens during pregnancy. During pregnancy, we'll know that physiologically, naturally, insulin requirements increase, and the body has to face this increase. One part of this increase is due to naturally developing, occurring insulin resistance, and we're going to see whether this naturally occurring insulin resistance can be also worsened by extra phenomena. On the other hand, when this insulin resistance produces increased risks, increased needs for insulin, and we need to develop, the body of the mother needs to produce more insulin. Some of these women, they do not produce enough. So we have at least two players in this phenomenon, in this pathologic phenomenon to be developed. One is the development of insulin resistance, and the other is the lack of capacity of the mother to face these new needs. So let's see how insulin resistance can be influenced by maternal adipose tissue in pregnancy. This is a beautiful cartoon coming out for more than 150,000 women from the N. Haynes epidemiological studies in the United States, which is very interesting. The continuous line represents the nulli gravida women, women that never had a pregnancy. And the spotted line represents women who had at least one pregnancy. And you see, independently or even taking into consideration the increase of the BMI, because as you can see here, we start with BMI 16 and go up to BMI 28 for this post-pregnancy or non-pregnant at all women. The women who are nulli gravida, they develop adipose tissue reserves at the level of their thigh, whereas the women who have been pregnancy at least once, they develop adipose tissue reserve at the level of the waist. So it represents the visceral fat, which is, let's say, the bad fat. Even women with BMI 21 or 22. This is a very interesting, to my view, point of physiology. And here, the authors have tried at 2016, this review, to put together all factors which actually, with the knowledge that we have gathered all these years, will lead finally to GDM. And you can see that here we have environmental factors having to do with the environment, including overeating, which can lead to obesity. We have stressful situations, either internal or external to the mother, including inflammatory conditions and mitochondrial dysfunctions, which might result from the aged body physiology of the mother, because now, you know, particularly in Western countries, we see more and more women who are going to pregnancy, particularly through IVF, in older age, so this is very important, and of course epigenetic changes. All these factors, obesity and stress, have been suggested to influence the development of insulin resistance, and this is what we're going to see in this talk. So factors affecting the endometrial environment are definitely maternal. So it's maternal metabolism, dietary habits, and anthropometrics of the mother, whether she's obese, whether she's obese with visceral fat, and then of course her psychological and behavioral and personality factors, which are often neglected, although in the lay tradition, the population tradition, one of the most important things when we deal with pregnant women is to keep these women calm and happy. And then the other part is the placental growth and function. So many years ago, or almost more than 15 years ago, we started prospective studies with pregnant women which they had normal weight or a little bit overweight, but they had normal pregnancies. And then we studied the same women in the same cohort of women during the first, second, third trimester, and even at postpartum. This is the only effort that I have seen to my search through literature has ever been done with the same women through the whole pregnancy. And we performed different tests, and among them, of course, 75-gram OGTT tests. And by doing mathematical calculation on the results of insulin production and glucose production during these OGTTs, we were able to extract interesting markers such as insulin sensitivity index, or the markers of first phase and second phase, which represent the first phase and second phase of insulin secretion during OGTT. And we correlated these markers of insulin secretion and insulin sensitivity with different parameters of this pregnancy. And here we have parameters regarding the anthropometrics of the mother. And you can see the maternal weight, even the weight before starting pregnancy, is highly associated, correlated, even in the first, second, and third trimester with insulin sensitivity index. So when we have a woman in front of our eyes before even getting into pregnancy, and she wants to get pregnant, and she is overweight, or even more, she is obese, we can be sure 100% that this pregnancy is going to develop insulin resistance, and we have to tell her this. And even when maternal BMI before pregnancy has been correlated by my colleagues with the fetal insulin secretion, and the cord blood C-peptide has been highly associated with them, showing that an overweight woman, an obese woman, is going to produce a baby which is going to be hyperinsulinemic, and this is very important. This has also been verified in the past by other famous authors such as Pat Catalano. Now, this is the adipose tissue, and we know this representation for many times, we have seen that, but I wanted always to attract your attention to these black spots here. What are these black spots? These black spots are macrophages. The adipose tissue is full of macrophages, is full of cells which have to do with the inflammatory response. And when we stain these macrophages with specific stainings, here you can see this brownish color of macrophages, you can see that in obese patient plus adipose tissue is full of macrophages, so an obese person is in inflammatory condition because of its adipose tissue. You know that very well, because they have increased CRP, C-reactive protein. But why these macrophages are important? They are important because they produce the inflammatory cytokines. You see in this old work by George Cruzos that when in a body we have increased TNF, we have increased IL-6, and this body belongs to a fat person, it goes along with leptin, which is a very good marker of adipose tissue. So these inflammatory cytokines, you know very well, they influence in a negative way the activity of insulin, either by acting on the IRS1 or acting on the production of GLUT4. So glucose cannot get into the cell, and also the message of the insulin doesn't go through IRS1, and so hyperinsulinemia will result inevitably. But not only this, in obese women who are getting pregnant, we have macrophages which are found in the placenta itself. So the placenta itself becomes inflammatory. Why? So let's keep this in mind, the inflammation which is produced during obesity and from the adipose tissue, and then let's move to the markers which have gained an important place in our life about 25 years ago, when in 1995 first leptin production was described. And we see that the most known adipocytokines are adiponectin, leptin, and resistin. Resistin didn't gain so much importance through the years, but then I would like to talk to you about a fourth adipocytokine, which is visfatin. And all of them, they are produced in different sites in the body, including, of course, adipose tissue, but they are also produced by the placenta itself. And so this is very, very interesting. For example, here you can see that leptin is produced by the placenta, but even its receptor on the placenta. Not too many details are known about leptin physiology in the placenta, so there's a lot of work to be done. But I would like to shift gears and attract your interest on visfatin. Visfatin is a very peculiar molecule. It was first discovered about 30 years ago. And every 10 years, I like to say that, it changes its name. It was named nicotinamide phosphoribosyl transferase, then pre-beta cell colony enhancing factor 1, and then it was named visfatin. So what it is known, which is very interesting for us in this hall here dealing with diabetes, is that it's a molecule which activates insulin receptor. Here is visfatin, it comes out from the adipose tissue, has insulin mimetic effects, and improves insulin sensitivity. And so in studies which took place almost 20 years ago, we see that the more a person is seriously diabetic, and you will agree with me that most serious diabetic are people suffering from diabetes type 1, the more they have visfatin, as if the body, through the different ways it has to produce visfatin, tries to find a molecule which is going to facilitate insulin activity in these patients who need insulin desperately. And also here you can see in a study 18 years ago, in different cohorts of women, first trimester, second trimester, third trimester, and post-delivery, that the more the pregnancy progresses, the more visfatin goes up. It is exactly the same thing we found ourselves in the first trimester, second trimester, and third trimester with statistically significant increase of visfatin in normal pregnancies in the same cohort of women. So when we turned back to our mathematical calculation and we associated our findings regarding visfatin and leptin with the mathematical calculation of insulin production during normal pregnancy, we found definitely that leptin is associated in the first and the second trimester with hyperinsulinemia. Here is the second trimester, here is the first trimester, also in second phase of insulin production, also with the area under the curve of insulin during the OGTT. And of course, its negative association with insulin sensitivity index. The more leptin you have, it represents an important amount of adipose tissue, the less insulin sensitivity you have, because apparently this is due to the increase of inflammatory cytokines, as we saw a little bit before. Adiponectin doesn't change much in normal pregnancies, and we didn't find a change. However, Pat Catalano has shown in the past that adiponectin, which is also a positive for the insulin sensitivity adipocytokine, decreases during pregnancies with GDM. However, even in normal pregnancies, visfatin goes up from the first towards the third trimester, and it is associated, and this is very, very interesting, please pay attention to this, through regression analysis, that if we measure visfatin at the first trimester, and we measure the inflammatory marker high sensitivity CRP at the first trimester, this can predict the possibility of having development of insulin resistance during the second trimester. And you know that one of the biggest problems that we face in diabetes of pregnancy is that we do not have a good marker which can help us to predict which woman in the beginning of pregnancy is going to develop insulin resistance and possibly gestational diabetes during her pregnancy, because only on the 24th week we can perform standardized OGTTs. Whenever we perform OGTTs before the 24th week, we do not have markers because they are not standardized. We do it, but we don't have markers. And so you can see that, interestingly enough, visfatin in the mother is negatively associated with the hip adipose tissue, definitely and obviously because the hip adipose tissue is not the negative one, but on the contrary is associated with the visceral adipose tissue. The more visceral adipose tissue you have, the more inflammatory you are, the more insulin resistance you produce, the more hyperinsulinemia you produce. It's exactly there when visfatin is needed. Where is it produced from? We do not know. It could be produced by the mother itself, by her adipose tissue. It could be produced by the baby itself, by its adipose tissue, but it could be possibly also produced by the visfatin. This was our Princeps publication in 2007, but even since then, nobody has shown where this visfatin comes from. And just to add a notion of how the body of the mother tries to respond to the development of insulin resistance, which might produce gestational diabetes, I will show you what we found regarding the amounts of GLP-1, the natural and inherent GLP-1 of the mother, which increase at the third trimester. And so I would conclude that during pregnancy, physiological, natural insulin-resistant development, the maternal body or the placenta goes to a compensation through increase of the visfatin levels and also through increase of GLP-1 maternal production. And now moving to the last part of this talk, I would like to shift you from the importance of the adipose tissue of the mother to the importance of the reaction of the HPA axis, the hypothalamic pituitary adrenal axis, to stressful stimuli to the mother and the baby. You know, during pregnancy, we have three sites from where the adrenal production is regulated, both the maternal and the fetal adrenal production. We have in place the adrenals of the mother, which are influenced by her own hypothalamic pituitary adrenal reaction. We have the adrenals of the baby, which is influenced by its own hypothalamic pituitary adrenal reaction, but we have also the placental production of CRH. Here is the placental CRH, which we have shown to be produced about 30 years ago at the lab of George Kruzos. So all these parameters, they are accommodated in order to regulate the response of the mother and the baby to stressful stimuli, so the pregnancy goes ahead positively. But here there is a major danger which can appear. When mother reacts to a stressful stimuli, cortisol is produced. This is normal. But if this cortisol goes to the baby, then it can go to the brain of the baby, and we know now that cortisol destroys neurons. And the placenta has a possibility to block this passage of maternal cortisol. How? By using the famous 11-beta hydroxysteroid dehydrogenase type 2, which transforms cortisol to cortisone and inactivates it. But if a problem appears in this barrier, then the cortisol will go to the baby. So this is very important for the body to face it, because stressful situations can act through cortisol, which can go through the placenta and can epigenetically affect either neurogenesis, but also can affect many other functions of the body of the baby, and I'll stay there. So it is an important issue, the mother not to be stressed. I think it makes sense. But is it possible that maternal stress has anything to do with glycemia of the mother? let's see this that we have studied a couple of years ago when we gave 2 questionnaires to the mothers. Each one has only 20 questions. They are called STI questionnaires. One examines the trait of character of the mother, whether she's an anxious type, a depressive type, and the other examines the state of the mother, when at the moment of the questionnaire she is anxious. And we extrapolated the role of anxiety with the role of stress. We do not have today, till now, specific tools to assess the stress per se. So we have to extrapolate our knowledge regarding anxiety. And what did we find? That if you study these questionnaires at the 2nd and 3rd trimester, even when you divide them to the most stressed and lower stress, you see that they are associated with the CRH of the placenta. 2 seconds, and I'm done. So the CRH of the placenta is increased when the mother is anxious. So how this happens? Because the mother is getting anxious in her brain, but there is no neural connection between the brain of the mother with the placenta. And what did we found? We found that many years ago, in 1989, in studies in sheep, CRH-like activity was detected in the plasma of the uterine and umbilical vein, and when these sheep were stressed, there was reduction of uterine blood flow, elevation of maternal adrenaline, and increase of CRH placental output. So this was also shown by OBGYNs who they found association between maternal anxiety in pregnancy and increased uterine artery resistance index, meaning that when the mother is getting anxious, adrenaline and catecholamines are produced, and these catecholamines drive decrease of uterine artery blood flow, which results to increase of the CRH, increase of cortisol, and the baby is getting more anxious. And final slide, you can see that the more the mother is stressed, the less the insulin sensitivity goes down. This data, published in 2017 in Psychoneuroendocrinology, have convinced at least our team that when you have a stressed mother, the increase in her cortisol will lead to decrease of insulin sensitivity index, and this is a functional cause of development of hyperinsulinemia. And I will finish there here for the sake of the time, and I'm sorry if I have been taking more than expected. And I hope that I have just given you the idea of 2 major factors not well studied regarding gestational diabetes mellitus. One is the adipose tissue of the mother, even the pre-pregnancy gestational diabetes, and the second, the role of the stress. Thank you very much.
Thank you. We'll then call on our second speaker with questions. Perhaps we may have time at the end. So.